So I'm just going to briefly describe a project we're working on with kids with cerebral palsy. We developed a respiratory monitor um, to see if we can monitor some of these kids' breathing. Because typically some of the higher level CP kids, they don't have pulmonary function tests unless there's some issue with them. So what we've developed is a non-invasive, easy to use sensor. They can measure some of the parameters of their breathing. So quickly, as I run through these slides, CP, generally, most of you probably know about CP. It's a congenital condition, non-progressive neurological insult at birth or prior to birth. And it's one of the most common or the most common childhood motor disabilities. And we are looking at, this gives you on the top right, this chart gives you roughly a breakdown of the levels of disability um, measured by the GMFCS score. So it's just a measure of different joints and muscles and their motor ability. So we're looking at the most severe, which is GMFCS 4 and 5. Um, just basically, these are some of the pulmonary issues. You could have a newborn or a premature baby with BPD, bronchopulmonary dysplasia, which is just damage to the lung. And then later on, you can develop asthma, aspiration, obstructive sleep apnea. And then this can also apply to other neuromuscular conditions like Duchenne muscular dystrophy, Becker muscular dystrophy, spinal muscular atrophy, skeletal dysplasia. I'm going to skip this. Yeah, so I'll get to that later in a later slide. Um, so one of the issues is they don't, as I said, they don't have pulmonary function tests as a norm in the clinic. Because they're just not capable of doing it. It requires voluntary effort, and some of these kids are at so high level that they're unable to perform that. So we've developed something that's non-invasive and doesn't require their effort, which passively measures their breathing. These are examples of typical pulmonary function tests done in the clinic and in the lab. Typically, you do spirometry, which requires you to breathe in a certain way and apply maximal breathing effort. And some of these kids with CP and other disabilities just are unable to do that. Respiratory inductance plethysmography has also been around for a few years, which is what we'll look at. You apply bands around the chest and abdomen and see how your lung volume changes as you breathe. And from that, can you detect um, any conditions that are abnormal? You could have a version of that in an enclosed tank essentially. So you sit in this enclosed tank that measures pressure differences and so on a little more accurately. But again, very hard to do with some of the kids with CP. This is on the right, you see the system of RIP, which is respiratory inductance plethysmography. We just call it RIP. And it's just a cumbersome, large system that's hardly ever used in the clinic because it's just hard to get real-time data and clinically relevant data for the physicians. So it's seldom used. Basically, as we breathe, in normal breathing, our rib cage and abdomen moves in sync. So as we breathe, you see those sine curves. They should be totally in phase if we're breathing correctly. So gas exchange is very efficient. If you aren't breathing efficiently, your abdomen and chest move out of sync and you get a phase lag. So it's that phase lag that we're measuring with our device through these bands. And the higher that phase lag, the worse the breathing condition is. You're just, carbon dioxide is moving from the top of the lung to the bottom of the lung and vice versa. This is a picture of our system. Actually, this is one of the older systems. On the left, you can see me holding that black box. And that's hooked up to these bands. And the bands have a wire in them, a sine waveform wire embedded in that band. As that band expands, the inductance changes. And that's essentially a measure of the volume change in your chest and abdomen. And again, if these two bands aren't moving in sync, there's an issue with breathing. So what we've done is try to improve that old system that's hardly ever used. And through Bluetooth, you can see this girl on the right. She has the bands on, and that sends that signal through Bluetooth to an iPad, and you can assess in real time what's going on with the breathing. This is on the right, on the left is a new, and on the right is a newer version of our sensor, and that's hooked to the bands. So this is used in the clinic now as a research tool, and typically the whole test takes about 3 to 5 minutes, and you can access the data and gives you all kinds of charts and so on. And we're using this in CP. I'll get to that in a second. This figure just tells you the parameters that come out of this measurement. One, as I said, is a phase angle. If you're at 180, it's paradoxic breathing. That happens in BPD kids or premature kids where you're just breathing completely out of phase and it's very inefficient. Another measure is a measure of how labored your breathing is. It's just kind of another measure of the phase angle change. And then percentage rib cage, the third one here is the percentage of your volume that's due to the rib cage expansion. And that should be about 50% ideally. So your abdomen and rib cage are moving together. And then breaths per minute is an obvious one. This is a typical output of our device. On the left, you see the screen from the iPad. This tells you respiratory rate, phase angle. As the graph tells you, the blue and orange, they're completely in phase. So breathing is almost perfect here. Rib cage is 85. I'm not sure, that 85 doesn't correspond to this because it should be 50-50, but that's the previous window. LBI is, ideally it should be 1. LBI is a ratio of your movement if you were completely in phase versus what your denominator is versus what you actually are. So if you're breathing perfectly, that should be 1. The higher that number, the worse you're breathing. On the right, it gives you an example of 2 in phase. You can see that plot totally in phase, and then completely out of phase at the bottom on the right. This is just how we compared this to the existing respiratory system, and we had favorable results. I won't go into that here. We've had different applications of this this sensor we developed. One is we're continuing to study kids with muscular dystrophy and SMA in the neuromuscular clinic. So again, we're collecting data as they come in periodically in their clinic. We've done it on Morquio syndrome, neonates with Christiana care. And an interesting study, which we got a NIH STTR for, was pain management in yoga therapy. So kids doing yoga therapy are asked to breathe a certain way. So we wanted to see how compliant they are with that, and whether with with biofeedback, we can change some of that breathing in some of these kids who have chronic pain as they're doing their yoga therapy. Results were kind of mixed in that study. And then another study was inhalation and anesthesia right prior to surgery. This is, again, quickly just the bottom, the yellow highlighted shows you that patients with muscular dystrophy had worse phase angles, as you can see in the yellow, the first line. It's 50 compared with our healthy controls, which was 24. Anything below 30 degrees is considered normal. So we can see that they were in the abnormal range breathing. So to come back to our study with CP, we had two goals. Since these kids don't typically have pulmonary function tests, we're applying our sensor in the clinic and seeing if we can pick up any predictive values that signify an issue down the road in their breathing. Unless they have pneumonia or severe cough, they're just never tested for their breathing issues. So this might pick up downstream issues with breathing. And then we also, these higher level kids with CP often have scoliosis to a varying degree. They're in a wheelchair, so that exacerbates their scoliosis. So we want to see how that affects their breathing. Because, as a curve, um, as the spine curves, that compromises your lung function. Just mechanically, you're pressing on organs, including the lung. We're continuing this study. We're a little over halfway through it, and our goal is to collect 250 or so kids who come through the clinic. We put these bands on and do our 5-minute test. And we also measure their gas exchange, their carbon dioxide as they breathe out. I won't get into that here, but you can see, let's go back. Some of those columns here, phase angle, we measure that. We measure labor breathing index. And we don't really have conclusions yet. It's still early on. We've done about 110 subjects, which is quite good for this population and this study. Nothing like this has been done has been done before. These are just other examples of graphs that we pick up. There's some that are nice and clean. With a sensor, we have one issue. It doesn't like movement. So if a kid is moving their arms or moving their torso around, it picks up these movement artifacts, which we try to filter out, but don't always get. On the top left, you have a clean signal. This also is paradoxic breathing. You can see the rib cage and abdomen are moving completely in opposite directions. So that phase angle is really high, totally out of phase. On the right, you have slightly noisy signal, but it's still in phase, and we can pick that up. And we're also measuring these kids at different time points every 6 months. So we have some with we have 3 time points for some of the kids. So we can see if there's any kind of progression. And again, on the bottom, we have some out of phase subjects. I can skip this here too. This is telling us with CP, if you look at the first column, the phase angle, for some of our normal controls, which was healthy teenagers, we had, I think, 20, and they were asked to breathe normally without moving at all, and we had beautiful signals. 14 degrees phase difference, which is well below normal. or it is well within the normal range. And then CP, you had 47, which is higher for an N equals N of 60 in this case. Same thing with LBI, the labored breathing index. Ideally, you want it to be 1, which it was in the controls, and then on 1.21, which is high. Breaths per minute here. We see a difference, which is interesting. We haven't looked at why that is yet, but that's something to look at. And this is an R21 grant, which, as I said, we're halfway through. Hopefully, we'll get some useful data in terms of scoliosis and how it relates to, or how scoliosis relates to breathing, and whether we can pick up any signs of impending breathing issues. And these are some of the people involved in the grant, the project. And that's all I have.